Thank you, Dr. Murray, and the coordinators. It's a pleasure to be part of this team. So the question really that we want to address is, how do we go from the fetus that we're imaging to a happy baby? So with regard to fetal echocardiograms, many abnormalities that we will detect could be incidental, mild, or not really needing any early intervention or expected to cause any symptoms in infancy. It's not that it's not important to find those, but they're not really expected to cause any changes in the pre or postnatal management of the baby and the mom. And these would include things like atrial septal defects, ventricular septal defects, unless a very complex type, minor valve abnormalities, minor vein abnormalities, such as a duplication of left SVC, and minor abnormalities of arteries or vessel size. There are, however, significant abnormalities that we can pick up, and these fall really into what I would kind of categorize as three groups. Those where there's some type of expected prenatal morbidity or even demise, and there's therefore a need for in utero intervention. Those where there's an expected need for tertiary neonatal management and surgery. And then a subcategory of that is those in which there's an expected need for emergent neonatal management or intervention. So what should not really be missed during a fetal echo? It would be those abnormalities where there's a potential for fetal intervention, those complex congenital heart defects where ICU medical management and eventually intervention or surgery is going to be necessary in the newborn period. And then again, a subset of those would be critical lesions where there's a need for emergency intervention in the newborn period. So this is an example on the over here of a heart that you can see is beating way too fast. And we do what we call an M mode, which is where we can look at the mechanical motion of the atrium and the ventricle, which is sort of equivalent to the electrical activity, although it's really mechanical activity, and that's what we see on the panel over here. This is the atrial motion right here. This is the ventricular motion right here. You could see that there's a 1-to-1 correlation, but the heart rate is way too fast at 260 beats per minute. So this is a case of fetal SVT, supraventricular tachycardia. This is another heart going extremely fast. On the M mode over here, what you can see is that the atrial activity is really extremely fast. The ventricular activity is less fast, although still fast, and this is a case of fetal atrial flutter. There are complications of fetal tachycardia, which can include things like tricuspid regurgitation, which is what's going on over here, and a fetal pericardial effusion or hydrops, which is what's going on over here. This fetus no longer in tachycardia. So complications of fetal arrhythmias, as we said, include hydrops fetalis or even fetal demise. That's why we care about them and want to intervene. Risk factors, and I think we'll have another talk about this later, but include heart rates greater than 190 beats per minute. Beyond that rate is actually not otherwise considered a risk factor. Sustained tachycardia for at least 12 hours. The mechanism of tachycardia is not actually important in the leading to demise or morbidity and earlier gestation. Favorable features include heart rates that are less than 190 or an intermittent nature to the tachycardia or isolated or even frequent premature beats. We can treat the fetus by treating the mother. And again, we'll have a talk on this later, so I won't go into it. There's up to a 90% success for termination of tachycardia, or at least for avoidance of hydrops. This is a case of needing team management, including fetal cardiology, pediatric electrophysiology, maternal fetal medicine, and often adult cardiology or internal medicine, as it requires monitoring the mother for the proarrhythmic effects of the medication, and obviously monitoring the fetus for success of tachycardia termination and fetal well-being. So here we have a different case. In the first panel, you could see what looks like a fairly normal 4-chamber heart over here. When we take a closer look, though, here, this is the left ventricle, which actually looks a little bit hypertrophied, and the right under my cursor right here is the aortic valve, which is thickened and a bit small. And then when we look at the color right here, we could see some turbulence across the aortic valve, and so this is a case of fetal aortic stenosis that was picked up at 20 weeks. So we saw her back at 24 weeks, and you can see in this first panel here that although the ventricular function is still okay, it's not as good as it was during the echo 4 weeks later. There's some echogenicity of the papillary muscles of the mitral valve right here, which generally comes, we think, from subendocardial ischemia. And then in the color compare panel over here, we see at least moderate mitral regurgitation. So this fetus actually went for a fetal intervention, a balloon valvuloplasty of the aortic valve. This is not this fetus actually, but images from the literature. But you could see right here, this is a needle and a wire going through the abdomen, maternal abdomen, into the uterus. And this is the left ventricle right here, and this is the aortic valve. In the second panel over here, the wire is across the, into the left ventricle. Here it's across the aortic valve, and this shows a balloon inflated doing a balloon valvuloplasty. So this is that same fetus at 27 weeks after the fetal intervention. We can see that there is some left ventricular hypertrophy here, but a restoration of really normal left ventricular function. So fetal treatment of structural heart disease is still fairly limited. It's really limited to aortic stenosis and occasionally severe pulmonic stenosis. With regard to the aortic stenosis, the goal is to preserve the left ventricular function and ideally the growth of the left ventricle so that ultimately these babies can have what we call a four-chamber or normal heart, essentially not progress to hypoplastic left heart syndrome. It generally consists of balloon valvuloplasty in the second trimester. We've learned that case selection is important. The majority of infants will need further intervention or surgery after birth, sometimes multiple, so this is important in counseling the families. And there certainly are still some fetuses that progress to hypoplastic left heart syndrome or need for a heart transplant. So moving to a different set of problems. This is a fetus with complex congenital heart disease, basically hypoplastic left heart syndrome. What you could see in this still image is that there's a large right ventricle here, but this is the sliver of left ventricle. There's mitral atresia, there's a smaller but fairly normal left atrium as labeled right here. Other forms of what we call single ventricle hearts include tricuspid atresia, which is what's shown here. So this is a normal left ventricle right here. The right ventricle in this case is quite hypoplastic with atresia or non-development of the tricuspid valve. This is a slightly more complex form of a single ventricle heart, what we call double inlet single left ventricle. This one you could see has two fairly normal looking AV valves or mitral and tricuspid valve, but there's actually one single ventricle that they both empty into with no ventricular septum at all. And this one you can see would be much easier to miss on your screening ultrasounds, and that's actually why this fetus did not present till about 39 weeks. So this is just a schematic showing the different forms where we have basically a very hypoplastic ventricle, either the left ventricle and hypoplastic left heart syndrome or the right ventricle and tricuspid atresia, usually with extreme hypoplasia of the artery that comes off of that ventricle. These and a number of other lesions are what we call ductal dependent lesions. They basically rely on blood flow to either the body or the heart from the or the lungs from the ductus arteriosus, the fetal structure that can provide that during fetal life, but we use that to provide the blood flow during postnatal life as well. So the postnatal management of these complex fetuses with ductal dependent lesions includes the infants developing either poor cardiac output or poor pulmonary blood flow due to some type of complex or obstructive lesion. They can develop shock or cyanosis. They need delivery ideally at or else rapid transfer to a tertiary or quaternary center where the subspecialty care and definitive surgery can be provided. There's a subgroup of these babies, and it's luckily a relatively small number, that require actually emergency intervention in the newborn period. And this is basically a small subset of patients for which there's no medical management for their problem and expected critical deterioration or death within minutes or hours without the surgical or cath intervention. And this is really essentially three type of abnormalities that we see: hypoplastic left heart syndrome with intact atrial septum, obstructed total anomalous pulmonary venous return, or extremely poor left ventricular function. So this is a case of the baby with hypoplastic left heart syndrome. You could see that there's essentially only one ventricle. It's the right ventricle. The very tiny left ventricle is barely in view right here. Then when we let it play, we can see this really thick thing over here. And on the still picture, this thick right here is actually the atrial septum. It's very thick and there's no flow across it. So when the baby is born, there's really no way, once the left atrium fills with blood, for that blood to get anywhere, because there's mitral atresia and there's an intact atrial septum. So these babies need delivery by C-section in close proximity to the cath lab or the OR where the next procedure can take place, with immediate transfer of that baby to the cardiology and anesthesia team, an urgent atrial septostomy, and only then transfer to the ICU, let them recover for a few days and continue with their surgical care. Obstructed total anomalous venous return is a situation that generally occurs when the pulmonary veins come to a single vein that goes below the diaphragm. Obstruction can occur at the diaphragm, or often the connection to the right side of the heart is through the ductus venosus, which closes after the baby's born. These babies, again, have no way to actually get blood into the left side of their heart. They have no cardiac output and can rapidly progress to shock or death. There's really no medical management, and urgent surgical intervention is needed. So key takeaways is what fetal cardiac issues should not be missed. Ideally, nothing should be missed, but the most important issues are those that are going to involve morbidity or demise if there's not appropriate timely treatment. That may include prenatal treatment in the case of arrhythmias, or those small number of cases where there's options for fetal surgery, or more likely coordinated postpartum care, congenital heart disease that's associated with poor cardiac output or severely restricted pulmonary blood flow, including the list of problems that we've outlined. And those should obviously be delivered at a surgical center so that the process of care of those infants can begin right from the time of birth. Thank you.